once the genetic code of the virus was provided. That was done in 2016. And when the COVID epidemic came along, Moderna used that research and used federal support of further research to develop its COVID vaccine. Now that is the system, that part of the system is working. COVID vaccines were developed early on. The United States had the Operation Warp Speed that was presented by President Trump. And I agree with what he did. He just threw money at the problem to try and get vaccines out as quickly as possible. And Moderna was very happy to take the money. So the bottom line here is that Moderna made a fortune. Moderna's CEO is now worth almost $4 billion. And that $4 billion is basically comes from the federal funding of the infrastructure research of developing the mRNA vaccines, and then the federally funded research to develop the COVID vaccines. So now we've got scientists who are able to become enormously wealthy, far wealthier than they need to be to motivate their scientific discoveries. And what's happened is that the universities themselves have been they've been taken into the marketplace, and much of what they do is determined by how profitable their activities are. So in 1981, Derek Bok was president of Harvard University, and he was reflecting on this potential commercialization of universities and wrote in Harvard Magazine that there was developing an uneasy sense that programs to exploit technological development are likely to confuse the university's central commitment to the pursuit of knowledge, that the money will confuse the university's commitment to the pursuit of knowledge. And I would like to add to that, and I assume that President Bok would agree, it's not just a university's central commitment to the pursuit of knowledge, but universities are tax-free institutions, and they also have a commitment to knowledge that's produced for the public good. And what President Bok was saying is he's worried that that public commitment is going to be displaced by the financial opportunities. So this is the context in which our medical knowledge is now being produced. And I want to ask two questions about that medical knowledge. And the answer to those two questions is imperative to figure out why we've dug ourselves into such a deep hole. And you can't understand what's going on here. It's not, the answers aren't simple, that drug companies are greedy, that insurance companies game the system, and so forth. Those are problems, but those aren't the core problems. And we have trouble fixing those problems, but we're not going to fix American healthcare until we get to the core problems. So question number one is the new medical knowledge that informs healthcare professionals and policymakers epidemiologically balanced? In other words, is that knowledge produced, is the research funded, and is the knowledge produced in order to create new knowledge that will best improve the health of Americans? Is it a public health market that's funding this research, or is it a commercial market? Is that knowledge funded, produced, and disseminated in order to make money for commercial players? And what we find out, I think you can guess what the answer is, but what we find out from an article from JAMA called The Anatomy of Medical Research, this data I think is from 2013 or 12, the United States spends $116 billion annually on research directed at new drugs and medical devices, but only $5 billion aimed at health services research, which examines access to care, quality and cost of care, the health and well-being of individuals, communities, and populations, exactly the things that were measured in that graph I showed just minutes ago that showed how the United States was failing in comparison to the other countries to have a well-functioning healthcare system. Well, Why are we spending 96% of our research money in drugs and devices and only 4% on population health and primary care and health systems that work more effectively and efficiently? The answer is obvious. One major difference is that new drugs and devices command favorable prices, and their value accrues directly to the firm that invests in them. In contrast, service innovations that can reduce morbidity and mortality, and let me broaden this to include service innovations, but this would include the social determinants of health, research on the social determinants of health, that can reduce morbidity and mortality while also reducing cost. But the financial returns from such research the financial returns based on that research is going to be not only negligible, but most likely negative. Because when we look at the social determinants of health, which will in a minute, we would find that much of the health that we're trying to improve is best improved by changes in how we live our lives, not by drugs. And if we look at the most widely prescribed class of drugs in the United States, it's statins to lower cholesterol. And we can talk about this in the question and answer session, but statins may reduce the risk of cardiovascular disease by 20%. But lifestyle modification reduces the risk of cardiovascular disease by 80%. Yet there's never been a study funded, because the statin makers fund the studies, there's never been a study funded that compared statin therapy to reduce cardiovascular disease, the risk of cardiovascular disease, to lifestyle modification to reduce the risk of cardiovascular disease. There's never been a study that asked that question. Why? Because of what you're looking at on this slide. The financial returns to be negligible or even negative. And what we have is a commercial market-driven system of producing the knowledge that informs our healthcare system. We don't have a public health-driven market to inform our healthcare system. Let's look at how, let me get it. Let's look at how this plays out, for example, in the growing prevalence of type 2 diabetes in the United States. This data is from 2007 to 2020. And if we start here in 2007 and go up to 2020, there's a 42% increase in the number of people who have type 2 diabetes. And as Pam Popper was saying in the last lecture, this is not complicated. It's because Americans are taking in more calories and they're not physically active enough to burn off those calories, and their weight is going up. As we see here, the obesity rate in the United States in the late 70s was 15%, and now it's 45%. So the obesity rate in the United States has gone up 3 times since the late 70s. 3 times. Now, our genes didn't change during those years since the late 1970s. What changed is the way we live our lives. But the research that's done is looking for money, it's looking for profits, it's not looking to improve health. So what our market does is it develops weight loss drugs for diabetic and non-diabetic patients. And instead of getting at the core problem, which is we're not getting enough exercise and we're taking in too many calories, what we see is that we're rapidly adopting the weight loss drugs, diabetic weight loss drugs, to solve this problem. We're solving it the wrong way. Now we've got in 2022, we had 5 million prescriptions of these weight loss drugs being written a year. It's about $1,000 a pop. So we're talking about $5 billion invested in weight loss drugs, the long-term effect of which we don't know, except we do know that when people stop taking them, they're going to gain all the weight back. And what we're doing is solving a social problem of not exercising enough and taking in too many calories with a drug, and that drug is going to have a side effect. It has to have, I mean, it has side effects with gut and nausea and so forth. But long term, nobody knows what the solution is going to do, but it's the wrong solution for the problem. And this is a perfect example of how the United States healthcare system got off track. Now, to fuel our going off track, let's compare the prices of weight loss drugs. Look at the top line, and you see in the United States, the 4 weight loss drugs cost about $1,000 a month. But look at the next line. In Japan, instead of Ozempic costing $936, it costs $169. And it costs even less per month in the other countries. It goes down to $83 in France. And the other drugs are far less as well. So part of the problem, when we think of high drug costs, we think of taking money out of the system, and it does. And that's a very serious problem. And that money could be reinvested properly in helping people to become healthy and to adopt healthy habits. But what we see is that in the United States, the profits are so high on these drugs, it doesn't cost any less to produce these drugs in the other countries. So this is all the difference between the United States and the other countries is sheer profit. It doesn't cost any less. So what we're seeing is that this enormous profitability, this way out of line profitability, is what pulls our system into the solutions that are most lucrative, not the most healthy, not addressing the problem at its root cause of how much exercise we get and how many calories we ingest. So the high cost of drugs not only just rips money out of American society, but it distorts our healthcare. And in fact, between 2/3 and 3/4 of the profits of the global profits from pharmaceutical companies come from the United States. So this is a major issue that distorts our healthcare. The second issue, that's the first issue, is our scientific evidence, is the evidence that doctors rely on as evidence-based medicine. Is it epidemiologically balanced so that it informs the doctors how best to help their patients achieve or maintain health? That's question number one. We're failing on that.